Since my topic is upper limb orthotics and like Dr. Venugopal told, opening batsman. So in my presentation, I believe giving introduction of orthosis also in addition to upper limb. My topic is upper limb orthosis, but since this is the first orthosis class for this course, so my some of the time will be devoted to upper limb introduction of the orthosis also. I think that will be helpful for future speakers also. Let us see. So what is an orthosis? Like most of the people who are sitting in audience must be aware. But recently I was in an exam, still people know to identify, but giving definition to an orthosis, sometimes they face problem. So what is an orthosis? It is a device which is applied externally to a part of body. And how this orthosis comes, what have come? This is like to ortho means straight. So basically, but orthotics are not only for using straight. There are many functions which we will see later, and they are sometimes called as orthotics. It is means exchange. You can either say orthosis or orthotics. This means synonym. And there are some terms called brace and splint. So brace is used when it is used to correct irregularities, and splint it is usually used after surgery and does not allow for movement. And the orthotist is the person who design, fabricates, and repair the orthotic device. So what are the benefits of orthosis? It improve function, save energy, increase endurance. The main aim of orthotic intervention is to function without dysfunction. Without dysfunction, that is the most important thing. When orthosis being used, it should function but without dysfunction. So what are indications for recommending orthotic devices? To relieve pain, to limit motion. When we need to limit motion, like immobilization after surgery, immobilization after traumatic injury, compression fracture management, and kinesthetic reminder to avoid certain movements. Then to correct deformity, like previous speaker was saying, posture, like similarly for scoliosis management. Then relieve symptoms of disease by supporting or assisting the musculoskeletal system, to reduce axial loading, and to improve function in a certain segment of body, assisted and improve movement and function. Reduce muscle tone, protect against injury, provide proprioceptive feedback, and provide rest. Now what is the prerequisite of a sound orthotic management? We have to do gait analysis if it is for lower limb, then whether there is spastic paralysis or flaccid paralysis, what is the major joint malalignment or contractures, joint stability, joint range of motion, active and passive. Then if for upper limb mainly activity of daily living such as grooming, dressing, feeding, hygiene. Then the design characteristic of an orthotic device, it mainly depends on weight of the orthosis, adjustability, functional use, cosmosis, cost, durability and material. And ability to fit various size of patient, ease of putting and taking off, and access to tracheostomy site in case of cervical collars, access to surgical sites for wound care, and aeration to avoid skin maceration from moisture. Now duration of orthotic use, it is determined by the individual situation. In situations where instability is not an issue, recommend use of an orthosis until the patient can tolerate discomfort without the brace. When used for stabilization after surgery or acute fractures, allow 6 to 12 weeks to permit ligaments and bones to heal. Now what are disadvantages? There are certain, it is not like orthosis is always useful. There are some disadvantages or limitations also of orthosis. Like previous speaker is, again I am quoting same thing, that you cannot use braces for full time. So it limit and mobility and range of motion of the joint, it restrict rotation around the joint, and movement is usually limited in a certain direction only. And weakness of other muscles in opposite direction will happen, and device is exposed to wear and tear, and it's need maintenance, care, cleaning, repairing, and frequent changing of, like if shoes are there, then shoes have to be changed. Then for this purpose, the patient or the client should be used maintenance of orthosis, even their attendants may be some need to taught. The patient should be taught for cleaning the leather, oiling the joints, and wash the orthosis if possible. And the orthosis should be simple and durable as possible. Now there are two types of mainly orthosis when we say orthosis: temporary orthosis or permanent orthosis. Temporary orthosis we say when we are using for certain time. We have a time life. We have a lifetime that only this time you have to use, and after that you have to remove. And permanent orthosis when we expect them to use either lifelong or for a very long period of time, and when deformity or paralysis cannot be corrected. Though sometimes we change the orthosis when there is some improvement or the patient gains some confidence. Then static orthosis, it is not like mobility of the orthosis, static orthosis or dynamic orthosis. Static orthosis does not allow movement, dynamic orthosis allows movement. Different materials are being used for giving orthosis, like metal, plastic, leather, synthetic fibers, or any combination. Plastic materials such as thermosetting and thermoplastics are the materials most commonly used in orthotic industry. Then in plastics, thermosetting materials, low temperature thermoplastics and high temperature thermoplastics. Thermosetting materials can be molded into permanent shape after heating. They do not return to their original consistency even after being reheated. And low temperature thermoplastics can be fabricated easy and rapidly with hot water or hot air and seizures, but they are mainly used in low stress activities when they are not very highly durable. Then high temperature thermoplastics require higher temperature, but they are ideal for high stress activities. These are the different materials being used. Leather such as cattle hide is used for shoe construction because it conducts heat and absorbs water well. Then rubber, it has tough resiliency and shock absorbing qualities. It is used for padding in body jackets and limb orthosis. Then metals, they are mostly durable, so that's why they are being used. But nowadays metal use in orthosis is becoming lesser and lesser, but still they are being used because they are heavy and but they are not cosmetically pleasing. It can be used for joint component, metal uprights, springs and bearings. Now selecting the appropriate material, for three major factors. Then strength, we have the maximum external load that can be sustained by material. Then stiffness, how much flexibility we want and how much immobilization we want. Then durability, then how long the person will be using it, that also will make a choice. Then density, corrosion resistance and ease of fabrication. Then coming to the orthotic design, biomechanical principles. There are three main principles. They are pressure, equilibrium and lever arm. The biomechanical principles assist in promoting control, correction, stabilization or dynamic movement. So what is pressure principle? It is equal to force. We already know in physics, if you recollect, force per unit area. And so there should be adequate pressure. If there is more pressure, then it will cause the orthosis itself may cause shearing, ulcer or pressure injury. Then equilibrium principle, again equilibrium means the forces and counter forces should be equal to 0. If there is a change, means there is imbalance in force, again it may cause injury or the person who is using it may not be able to use it properly. Then lever arm principle, this is again a very important when we fabricate orthosis. The size of orthosis, how long it should be, that lever arm plays an important role, because along the lever you can apply adequate force. Sometime to make it cosmetically pleasing, we will keep shorter lever arm, then the adequate force may not be generated. These three principles act independently on each other. So when we design or evaluate an orthotic device, we should check that there is adequate padding covering the greatest area possible for comfort to reduce pressure. Then the total force should be 0 and the length orthosis should be suitable to provide adequate force. Now general orthotic condition, the force at the interface between orthotic material and skin, the degree of freedom of each joint, number of joint segment and neuromuscular control of segment including strength and muscle tone. The material selected for orthotic fabrication, activity level of client and goal of orthotic fitting to meet the functional requirements of client with minimum restriction. Alignment, the correction of deformity or maintenance of body like musculoskeletal disorders, we use Milwaukee brace. Then dynamic splint to prevent scar shortening. In the neurological disorders, we use torn reducing AFOs and CTLSO for prevent motion of cervical region. Then movement, a joint may require assistance with motion or resistance to excessive motion. Then we use assistance with joint motion like AFA with dorsiflexion assist for dorsiflexor weakness, and neurological disorders like reciprocating gait orthosis assist with spinal cord injury. Then resistance with joint motion, like musculoskeletal, you can use shoe insert for patient with foot deformity and finger splints for arthritic hand, and neurological disorders, arm sling for neurological disorders, Swedish knee cage for unstable knee. Weight bearing, again musculoskeletal disorder, we can use shoe insert with metatarsal pad for diabetic foot. Then neurological disorders, heel wedge for a child with cerebral palsy. Protection, protective segment against further injury or pain. Then musculoskeletal disorder like functional knee brace, neurological disorder like cup splints for post-spinal cord injury. So now coming to nomenclature. The nomenclature mostly we use nowadays on basis of joint they cover, but other nomenclature are also there. The function they provide, the condition they treat, by appearance, name of the person who designed them. Sometimes name of the person is also used for nomenclature. Like Taylor brace is one example. Then mainly 3 systems are there for nomenclature. International Organization for Standards, which give anatomic region-wise name, like we say for orthosis according to the joint which is being incorporated in the orthosis. Or for upper limb orthosis, there is a American system of hand therapist classification which give function and body part wise, and that numbering type is there, and then McKeggie and Morgan. So this is the chart which describe the different type of this classification. Like for common name for humeral fracture brace will be humeral fracture brace, and then we can use as ASHT classification, non-articular splints humerus, and international oscillation it is not applicable, but McKeggie and Morgan we use circumferential non-articular humerus stabilizing. Similarly for tennis elbow, which is very commonly used in our day-to-day OPD thing, for in ASHT splint we call it 45-degree flexion embolization type 1, and in bracket number 1 has to be put, numbering also is there. For iOS it can be shoulder, elbow, wrist, hand orthosis, or only wrist orthosis. Then for McKeggie and Morgan, circumferential non-articular proximal forearm strap. Similarly for others, I will not go into detail. So usually we use this simple one. Hand orthosis and finger orthosis also there. Hand orthosis, finger orthosis, wrist hand orthosis, elbow orthosis, elbow wrist hand orthosis, shoulder orthosis, and there is one more, shoulder elbow wrist hand orthosis. This is mainly for upper limb. So based on function also, like supportive, functional, corrective, protective, prevent substitution of function, prevent weight bearing, relief of pain. Based on design, non-articular, static, serial static, static motion blocking, static progressive, dynamic motion blocking, dynamic traction splint, tenodesis, continuous passive motion orthosis, adaptive or functional uses. So these are some examples. Non-articular splint, then static wrist splint for carpal tunnel syndrome. Then this is again one more static progressive splint, then static progressive splint, then dynamic carpal splint, then dynamic motion blocking splint, then dynamic traction splint, tenodesis splint. Now coming to upper limb orthosis, finger orthosis will be first covering. So there will be some wrist overlapping of wrist hand orthosis also in this. So this is vernal knuckle bender splint. Then next one is spider splint. Then for box fracture it is being used. Then ulnar gutter splint. Then radial gutter splint. Then dynamic finger flexion splint. Then this is RIC tenodesis orthosis. Then resting pen splint. Then Bobath splint. Then Claynert flexor tendon repair splint. Then short opponent's splint, and then ulnar deviation correction splint. Then partial hand opposition splint. Then different types of finger orthosis like gutter splint we use. Then C-bar splint and the C-bar web splint. Then reverse knuckle bender splint is also there. Then this is very commonly we are prescribing in our this thing, swan neck splint and buttonware splint. So what are the functions? This block PIP, DIP hyperextension but allow normal IP flexion extension, used in arthritis or swan neck deformity, PIP, DIP volar plate injury. Then prevent overstretching of PIP, DIP volar plate, prevent further deformity, immobilize PIP in extension, DIP is free, used in arthritis. Then prevent deformity like in buttonware deformity, prevent bolstering of flexor tendons, A2 pulley injury. Then protect reconstruction, allow dynamic motion without immobilizing finger. Now next is hand orthosis, like it maintain, assist or provide a position by stabilizing a thumb in a functional position. Then wrist hand orthosis is commonly called as resting hand splint. It is used to prevent contractures, maintains neural static wrist, hand and finger. Then wrist hand orthosis, commonly referred to as cock-up splint. Cock-up splint can be either short cock-up splint when it is covering, like in this diagram we can see, it is covering up to palmar area. When it is covering finger also, then we call it long cock-up splint. It maintains wrist in slight extension. Then this is wrist hand orthosis, which is called tenodesis orthosis, usually used in cervical spinal cord injury that result in paralysis or prehension, creates approximation of second and third digit and thumb with active extension of the wrist. Then around the elbow orthosis, like either can be lateral epicondylitis brace, which we commonly call as tennis elbow brace. Then elbow sleeve, commonly used for minor tissue injuries, soft tissue injuries, compression, sprains and strains. Then other elbow orthoses are custom molded total contact elbow orthosis, can be used for prevention of contracture, fracture, embolization. Then may include a wrist or wrist hand component, may be custom made or over the count self. Elbow joints may be either static or dynamic depending on our requirement. Then comes shoulder orthosis, which is commonly called shoulder sling, used for shoulder immobilization. Now, what is the function in shoulder slings? Immobilization to promote tissue healing. Indications are AC, acromial joint injury, scapular-humeral fractures, then post-shoulder repair, post-op shoulder repair, arthroplasty, post-op tendon, artery or nerve repairs, rotator cuff injury, bicipitaral tendinitis. Then prevent overstretching of this glenoid humeral musculature and ligaments. Then it is used in brachial plexus lesion. Then decrease shoulder pain related to arm distraction and shoulder hand syndrome, upper motor neuron lesion or hemiparesis with subluxation, and keep hand and forearm elevated to reduce edema. Then next one is this, which I was telling, shoulder elbow wrist hand orthosis. This is commonly called as shoulder abduction orthosis, sometimes referred to as an airplane splint. It maintains abduction at the glenohumeral joint. It function immobilized to promote tissue healing. Indications are axillary burns, post-operative shoulder fusion, post-operative scar release and shoulder dislocation. It increase passive range of motion by soft tissue elongation via load prolonged stretch like serial static planing. It is used also in burns contractures. Then clavicular orthosis, which is also known as a clavicular brace or clavicle support, is designed to provide support and immobilization for clavicle fractures or other clavicle related conditions. It helps stabilize the collarbone, allowing proper healing and preventing excessive movement during the recovery process. Functions: it restricts motion to promote tissue healing. Indication is clavicle fracture, improve posture, forward shoulder posture, then reduce scapular or myofascial pain, cumulative trauma disorder, then increase or maintain passive range of motion like pectoral contractures. Then there are some advances also in orthosis, but most of these advances are mostly used in therapeutic setting. They are not given to the patient, mostly are used for training purpose. But this one device is the electric power prehension unit. It can be used independently by the patient. What does it do? Provide dynamic prehension with a locked wrist is the electric provide power prehension unit. It is an externally powered prehension orthosis that delivers energy from a rechargeable battery pack. There is a DC motor that closes the hand with one polarity and opens it with the opposite polarity, and there is a gross motion which operates a rocker type electrical switch, and typical pronation produces prehension and supination hand opening. This EPPU is a common question in not in MD but in DNB very commonly it is asked. This is sometime to remember this. Then there are other devices also which are more of used in therapeutic setting, like I was previously telling. One is MIT Institute of Technology device, which development began in early 90s and took over 10 years to become fully operational. It is a 2-degree of freedom system allowing displacement of the elbow and shoulder during hand movements made in horizontal plane. During the session, the patient's arm is supported in a non-horizontal orthosis, like we can see in this diagram. there is a orthosis applied to the hand of the patient. Then one called mime, in its distal end is fixed in an orthosis in which the patient's arm is placed. It allows the patient to make large amplitude movements in 3-dimensional. It is called mirror image movement enabler. Then very commonly nowadays many centers are buying this Armio. So it is arm weight support, it is exoskeleton for movement guidance, augmented performance feedback, grasp and release exercises, increase in active range of motion, increase in strength and endurance, facilitation of self-initiated movement, and increase in selective control. This is the scan for.
I want to know the difference between general tenodesis splint and the RIC tenodesis splint orthosis.
Pardon, I could not get it.
Sir, can you please elaborate the difference between general tenodesis splint and RIC tenodesis splint, sir?
Basically not any much different. The only thing name we say, but a tenodesis splint when we are using RIC, it provides more dynamic function compared to general tenodesis. But otherwise there is not very much difference. That provide more function, that is the only difference.